Senior doctor here raising concerns that an emergency department may have to shut because of severe pressures on the health service. That warning comes from Dr. Seamus O'Reilly, Medical Director of the Northern Health Trust. The Health Minister, Robin Swann, says that is not inevitable.
What we're asking for is the public to play their part as well in regards to how they actually access our medical facilities. So we've Phone First in place, we've out-of-hours doctors, so I'd encourage people to take those avenues as well. So it's not inevitable. I don't want that to happen. The people working on our trust, the people working on our EDs don't want it to happen either. But I think it's right that we put out that precautionary message that is what could happen. But nobody wants it to get there. So it's about really encouraging people to play their part. You do that by coming forward and get your vaccines, flu vaccines, boosters as well. So we're really encouraging and asking people to help us at this minute in time.
That's Robin Swann. And this comes, incidentally, after the chief executive of the Western Health Trust had to apologise because more than 60 people were waiting in trust emergency departments on Tuesday of this week due to a lack of beds in Altnagelvin or the Southwest Acute Hospital. Also, in emergency departments across Northern Ireland more generally feeling this sort of strain on their space, on their resources. For example, the Southeastern Health Trust confirmed this week one of their patients spent 12 hours in an ambulance before admission to the hospital. Deirdre Heenan is with us, Professor of Social Policy at Ulster University. Anne Watt is Director of the think tank Pivotal. And John Compton, former Chief Executive of Northern Ireland's Health and Social Care Board. Great panel. A lot of expertise around this panel. Pick up the phone. Welcome you to Talkback. Our team will get you on the air as quickly as possible. 03030 80 55 55. I've got my Twitter ready with the hashtag BBC Talkback, and I'm looking at your texts coming in on 81771. Any questions about how we can fix this, and particularly how we might look at the relationship of politicians to our healthcare? But we're asking you also to share your experience. What has been your experience of emergency departments and hospitals? Are you feeling the strain as a patient or would-be patient at the moment? 03030 80 55 55. John Compton, what is going on?
Morning. Well, it's a very difficult time, clearly, and hospitals are very busy, and EDs in particular are hugely busy. I mean, I think the issue here is not so much today. I think what's going to happen in January is the real question. We all know, anyone working in the service will know that Boxing Day is the busiest day generally in the year for GP call-outs. The hospitals tend to manage in January because elective care closes around Christmas. People don't want to come in for elective surgery just before and just after Christmas. So there's a bit of space. And with COVID, of course, that space is gone. So I think I suspect that most of what's going on now is planning for the first 3 weeks in January to see how well they can cope. And some of the signals being sent out are indicating there's going to be severe stress.
It's going to be very difficult, Deirdre. We've been here before, haven't we, with winter pressures, but this is really amplified through COVID.
It has been amplified, and I think John raises a really important point. This is about planning. We used to say in governance, if it's predictable, it's preventable. That's very simplistic for health, but I do think it's really important, the issue of planning. We know there are going to be additional winter pressures because it happens every year. More people are admitted to hospital. There's a lack of beds. The cold, when the temperature drops, increases illnesses. There are staff shortages. We've an ageing population, and of course we've COVID now in the mix. So we know all of these things add up to winter pressures. So I suppose the big thing is, what are we doing to plan for those in as far as is possible? So we know that, for example, the issue around the hospitals is not just the admission into hospitals, but a huge issue is getting people out of hospitals. So in terms of social care, what are we doing to try and expedite the journey for people through the hospital and out of the hospital? So, for example, we could be putting some money into step-down facilities where people are moved out of the hospital, out of that emergency position into an intermediate place until a care package is found. But those beds have to be ready, those systems have to be ready and waiting. And the question is, are we planning for that? Do we have the ability to put those systems together? Would we have the staff to run those types of facilities? And that's really what we are thinking about now. And then, of course, the other hand of that is you're trying to reduce the number of admissions to hospital. And how do you do that? You improve your communications, you boost the immunisation, so encouraging people to take the flu vaccine, pneumonia vaccine, and of course the COVID-19 vaccine. Trying to have a focus on prevention. So we know that a significant amount of people who are admitted to hospitals because of falls. How do you get the message across in terms of trips and falls, particularly for older, vulnerable people? How do we encourage people to use online systems? So we know from COVID that there are groups of the population who actually like the online systems and can find the answers they're looking for on online systems. How do we, I think a really big issue in Northern Ireland is how do we reduce the incorrect use of services? How do we ensure that people go to the right place and are getting the services that they need to reduce pressure? Because we can't really think about this as an emergency problem or an ED problem. This is a whole systems approach, and the pressure on one system is very often because people think they don't have access to other systems. And I know, William, you and I have talked many times about waiting lists and the impact of waiting lists, but a lot of this pressure is due to waiting lists, and it's the long knock-on effect of people being years on waiting lists, then having to go to their GP repeatedly, go to A&E, try to get short-term fixes for really what they need is a proper sustainable solution to their problem. So I think when we're thinking about health, we have to think of it in terms of a whole systems approach, including our social care system.
Just before I come to you, Anne, let me ask John Compton to respond to one of the texts here. No name on this, but it says, look, we need to all chill out a bit here. What is the difference between lying in an ambulance or lying in a room or a corridor? What do you say to that, John?
Well, I mean, I understand perhaps what the caller is trying to say, which is, things are very difficult, but let's not whip it into some sort of big crisis. It's the end of the world type sort of situation. On the other hand, I think if it was me or a family member of mine, or I guess for a lot of your listeners, and someone was spending a long time in an ambulance or a long time lying in a corridor, I think we'd have views about that. Health is more than the treatment. That's very, very important. That's the central thing. But it's how we treat people. Do we show them respect? Have we shown them dignity? Do we show them all the things that I think we would take for granted and would clearly want for ourselves? And some of the recent stories that have come out clearly don't indicate that there is enough availability of respect and dignity. This is not that criticism of the staff. It's just simply a matter of fact that we all expect to be treated in a way where we're treated individually and treated humanely and all of that. So I wouldn't I understand what the caller's saying in terms of what's the news story? ED departments are busy. Well, sure, ED departments are always busy. So, let's all calm down a bit about it. And I think there is a wee bit of truth in that, actually. I do think that we do need to be more measured in what we say, more measured in how we approach it in the midst of all of this. But nonetheless, you can't get away from the fact that what's been reported recently, I don't think anybody would feel content or happy with it.
81771 Desenard says clinicians should run hospitals, not politicians. The emergency department at Ulster Hospital was a shambles before COVID-19. Long waits for a bed at Christmas in 2019 in Des's case. And let's turn to that, the relationship between politicians and managing a complex organisation, or many complex organisations that make up our health and social care sector. When we look at how we approach the police, for example, we have operational independence within the police, but we also have a policing board, which includes politicians and other independent members for governance. Some have suggested that that model that we have with policing might be a much better model to translate into healthcare, to allow the medical experts to have much more operational independence. What do you think?
So I think that might help. So it could help to take some of the political heat out of the debate and hand it over to experts who can take a view about what the best way to deliver health service is across Northern Ireland. That would allow them to have more of a strategic view that wouldn't be overly influenced by particular local issues or by how services are delivered at present. And I think also it could help or maybe what we would need in parallel, is a more informed public debate about what a really good health service would look like. There's a need to demonstrate how changes to how and where services are delivered will result in a better health service here. So you might have to travel further for an appointment or for treatment, but that's part of a more efficient system overall. So I think getting that kind of expert debate going, and particularly involving the public in that, could be useful. But at the same time, my big concern about it would be you could end up with setting up a whole lot of new structures and a whole lot of processes that actually still get stuck with the same difficult decisions. I mean, we've seen independent reviews, for example, being commissioned in the past in Northern Ireland about how health service provision needs to change. Those independent reviews have happened and we haven't actually had the action. So my concern would be setting up a whole big process, new structures, it takes time, but actually the tough decisions are still there and it's still difficult to make those.
Bart on Twitter wants to pay tribute to the hospital care that he received from the Royal at the A&E. This is the other aspect of this, that people are getting good care. He says, I took my wee girl to the Royal's Kids A&E a number of weeks back for stitches in her knee. 3 to 4 hour wait to be seen after triage, but the staff couldn't have been more helpful. And they were apologetic for the waiting time. The hardest part, actually, says Bart, was getting a parking space. 81771, with your experiences as well, including those positive experiences, because our doctors and our clinicians and our staff are working very, very hard in very, very difficult circumstances. Deirdre, let me just pick up on what Anne's been saying there, laying out some of the issues to do with political governance. We need our politicians, of course, involved in something as basic and fundamental as health and social care. We absolutely need them to be involved. But we know that individual politicians, or ministers for that matter, they're also politicians. They will always necessarily be concerned about the impact of some of their decisions on the public's ability or willingness to vote for them.
I think that's absolutely right. And I think we have to be realistic, but maybe not try to conflate two things. So those people who say, let's take the politics out of health, that's impossible. Health is political. Decisions around health are political decisions. Maybe what they mean is, let's take the politicians out of the management of the health service.
Yeah,
yes.
I think that's what they mean.
And I think that is possibly a different thing. And I know that the King's Fund in about 2018 suggested that actually there would need to be an end to the political control of the NHS if it was going to be sustainable and long term, and they were able to future-proof it, because they really identified the politicisation of health as one of its biggest threats. And when they set it out, they basically said, because of the political system that we have, that it's short term, short electoral cycles, short funding cycles, that the NHS has fallen victim to this. And of course, we can blame the politicians, but the reality is there aren't really many votes in health. So even though it's something that's uppermost in the public's mind in terms of waiting lists, it doesn't really seem to feature in the same way in terms of politicians' agendas. And that's because they know there really aren't any votes in it for them. And perhaps we have to accept,
there are quite a few lost votes if you do something the public doesn't like, mind you.
Well, exactly. And of course, in Northern Ireland, we know that when we talk about reconfiguration and changing, the public hear closure. The public hear, you're taking away my local service. That's what you're actually talking about. And so the communication of what you're trying to do and shift the whole idea to a focus on outcomes is very difficult for politicians. So I think we have to give them a little bit of a break. But also, I think at this stage of 20 years of devolution, surely we should be able to reflect and say, this model hasn't actually delivered, particularly in the area of health and social care. So maybe it's time to move to a model like the Bank of England, where we have this independent body,
for interest rates and the rest of it.
Sitting there. Yes, and it sits within a system, but it also has that very important bit of independence. It can have long-term planning. It can address some of the superficial fixes that are put forward by politicians because they're under a different agenda. So I think, maybe we should actually look at some of the other models that exist across the world and perhaps borrow some ideas from NHS England.
I want to return to that.
It has not been perfect, but I think there are some ideas in NHS England that would really appeal to the public, not least accountability. transparency. And when we hear about large sums of money, as we've just heard, going to the waiting lists, the public would understand, where is that money going? How will we know that this money has been well used? Could someone please come and tell us what the outcomes of this decision have been?
Let me return to the Bank of England and the wider English models question in a second. Michael is in Newton Abbey. Hello, Michael.
Hello, good afternoon, William.
Afternoon, Michael.
William, I just wanted to say, and I'm not knocking our present health minister because I think he's doing a very, very reasonable job under very trying circumstances. But what I would like to say, for years, we needn't talk about the health service being underfunded now, because for years and years we've undercut the health service. And it has been a political football with all parties. That last speaker was quite right. The health service, education and all those things should be taken away from politicians because they couldn't organise it correctly, in my opinion. Our waiting list is unbelievable, even before the pandemic, right? So let's not blame the pandemic. It has made it a heck of a lot worse. But I feel, just please, everybody out there, don't take sick or don't take ill. Just either go along and have a good life, and then if you want to die, my thoughts on the whole thing is just die right away.
Oh, my goodness, Michael.
It's unbelievable. You've no chance in hospitals at all.
Well, you have some...
Let's not overstate
this.
It's because of the funding and the politicians.
Michael, let's not overstate this. I don't want to be encouraging people to have that feudalistic kind of depressing attitude, but thank you for your call. I understand you're upset about some of this. But we need to think carefully before we use language like that, I think. And John, this idea that our health service is massively underfunded, and it's an idea we hear a lot, and it's an idea which has merit, of course, but what percentage of the Stormont government's overall budget is health and social care?
Well, currently, I think it's about 50% of the block grant that comes across to Northern Ireland. So, I mean, at one level, when you're spending 50% of the block grant, some £6.25 billion, a colossal amount of money on 1.8 million people, you cannot turn around and then say there is no health service. There is a health service, of course there is. There's a huge amount of people working in it, maybe some 70,000 people working in the system in the middle of all that, doing often in a very quiet and unremarkable way, a quite fantastic job. And I mean, I do think it is important to keep perspective here. Yes, things are difficult. Yes, we will hear very difficult stories about ED departments and other things. But the counterbalance to that is that every day of the week, lots and lots of people get good treatment, modern treatment, the best treatment that's available in the context of the NHS. So there is a degree of requiring of balance, and not the more fatalistic view, I think, of your
John, do you not think we would have a more agile health and social care system, one that is more able and more flexibly able to respond to challenges, if there was more operational independence for those clinicians and those managers who are right at the centre of it? Let's take some examples, for example. If you wanted to close a hospital here, it's a big political issue. Mm-hmm. If you wanted to turn a particular unit into something else, for example, make it a specialist stroke unit, it's a big political issue. If you even wanted to change some of the services and the way they're deployed, big political issue. Not always the case in every other healthcare system. Those are operational decisions.
Oh, no, I mean, I couldn't agree with you more. I think one of the things that we have become slightly entrapped into, and again, I think it's because of the political perspective, is this over-centralising of decision-making. Change happens on the ground. The people on the ground are the best people to make the change, handle the change and steer the change through. Of course, we live in a system which is politically driven, and it's never, as Deirdre said, never not going to be politics. But I think we do need to get to a position where there is much more autonomy for people to take local decisions. And local decision, I mean, the idea that managers or clinicians working in a local area would turn around and take decisions because they thought they were just to punish the local community is nonsense. Mm-hmm. In my experience, people take those decisions because they're looking ahead. they're seeing the difficulties, they're seeing the direction of travel, they're seeing the improvements that are coming in terms of the things that the health service can do, not just today, but in 5 years' time and in 10 years' time. And you have to begin to shift and make the changes to make those happen. There's no point in waiting, because you can never catch up. I mean, I do think it's always wrong, as someone who had a lot of time in the health service with money and so, is to lead the argument with money.
Okay.
Because
I'm nudging away from that into those structural questions and the role of politicians and reorganising.
I think you're right. I think we do need to get a better system where there's more local autonomy. I think we can use, it's not about throwing everything up in the air and reorganising, and all the points that Anne has made are very clear that, if you do all of that, you get lots of unwanted side effects. But I think we have a system. There is no perfect system.
You get unwanted side effects no matter what you do, right? We can accept
Correct.
that. Let me read this text out, because I think this is. We're trying to get in touch with Mark, who on this text, who describes himself as a paramedic. Mark, you're not answering your phone. We'd like to hear more from you on this. But Mark is saying it is dire at the moment. Stroke patients waiting 2 hours for an ambulance. 2 hours is life limiting. This is the normal wait time now, says Mark. Heart attack patients, similar. People are dying waiting for us paramedics to get to them. This is shockingly horrendous. Now, I don't know more about what Mark is saying except what he's saying in his experience, and he's describing himself as a paramedic, but that is a frightening text to read in this programme today. Jim is in Lisburn. Hello, Jim. Jim is not there. 03030 80 55 55. We will try to... Oh, we found him. Is Jim there? Nope, not there yet. Hello, Jim. Are you there? He's not there. All right, 81771 for your text. Collie from Ocker says there are too many trusts for the size of our population. The communication on wait times in emergency departments needs to be better. The waiting areas need to be more comfortable. Triage nurses should have more powers to book and follow up consultants and the like. What do you think of this, Anne, in terms of the reorganisation? We haven't got time in the middle of a pandemic to reorganise our trusts. I get all of that. But in a population of this size, do we need all those health and social care trusts? Or should we not just have one overall body with a CEO, a coordinating senior team with operational independence, and a governance board, which includes politicians as well, but with much more operational independence?
I think for the population of the size of Northern Ireland, we need to be looking at delivering health services for Northern Ireland as a whole. So overall, I'd be saying, yes, we need much more rationalisation, much more looking at Northern Ireland as a whole, 1.8, 1.9 million people, and delivering services.
A unified trust,
on
as it
basis. Were. Yeah, delivering services on that basis. I think something, just to go back to what others have been saying earlier, I suppose there's a real focus at the minute on the winter pressures and the impact of COVID, and obviously on the waiting lists, which are just off the scale compared to elsewhere. There's a risk of just looking at that and just saying this is about more money to get through these particular problems, but really it all comes back to the need for reform in how services are delivered, and those are the difficult choices that politicians are not grasping at the minute. And that's understandable because they're faced day to day with very, very challenging situations. But we must find time and space to look at that long-term transformation of the health service so it can cope with ever-growing demand. And that has been highlighted in several independent reports in the past, and there just hasn't been the action that there needs to be. So I would say everybody knows that there's this great need for change, but what we haven't had is the willingness to grasp and to make those tough choices. And my fear with taking politicians out of that is that you could potentially create another longer process that creates more reports, more independent views, but still a lack of action.
This text from no name on it, but says I ended up in A&E in June because my GP gave me antibiotics a week earlier. It didn't see me at all, just give me antibiotics. It turned out I had a heart inflammation and fluid around my lungs. They kept me in hospital for 10 days. I was very ill, and I'm just thankful I took myself to that hospital myself. That's what some people are saying to us. James says John Compton and Professor Deirdre Heenan should be running the Northern Ireland Health Service a lot better than it's done lately. Both of them have spoken out over the years of how to improve it. Who's listening? Jerry in Downpatrick says Transform Your Care has delivered nothing to patients. Waiting lists are crazy. Pauline says, you do remember the striking nurses. Safe levels of staff being the issue. 2 months before this pandemic. Too many tiers of management, some very good, some very, very bad. Health service worked better during the Troubles without these waiting lists. And Kevin in Armagh says, training 300 nurses per year, thousands of nurses short. The sums don't add up. A lot of others talking about recruitment and long-term planning that is just not there, apparently. Jim is in Lisbon. We've found him. Hi, Jim.
Yeah, you can hear me this time.
You go off for a cup of coffee there, did you?
No, I was actually there, but they couldn't hear me. But anyway, all that aside, and the vagaries of the phone system. But yeah, I mean, this issue with GPs, I think, is one that needs to be highlighted a bit more. I had the same issue, barred from getting into the GP surgery, handed a prescription, picked up from the chemist. It didn't really work very well, and they basically said, well, if it gets any worse, go to A&E. And it was back pain, basically. Now, I decided in the end that I wasn't going to go and present myself at A&E because I thought it is back pain. It's not an injury. There's going to be people a lot worse than me, and I'm not going to clog up the system. I will suffer on and see, if painkillers and things will help right it.
Goodness.
But, it's like Fort Knox at the GP surgeries at the moment. Absolutely. And they are. And whether they deny it or not, a couple of weeks ago I heard somebody denying that this was the case. And it is the case. I mean, everybody's saying it. So, why are they saying they're not doing this? But they are. And that's what's clogging up our A&Es as well as all the other services that are required at A&E.
Jim, thank you very much. And you did hear doctors saying, well, it may be varied across different practices, but